Hello. Please feel free to introduce yourself as you come in. We'd love to hear what your role is in long-term care and where you work. Anything else that you'd like to share?
Good evening, ladies.
Hi, Dr. Nickel.
Hello.
Hi, Steve.
Hello.
Hi, Chandra. I hope I'm pronouncing that right.
That's right. Hi.
Hi.
Hello.
Hi, Rick. Got some more people joining here.
Hi, can you hear me?
Hi, John. Yes, we can.
Okay, sorry.
Hi, Christine.
Hello, Tony Leon from Victoria.
Hi.
Hi, I'm Chris from Langford.
Chris, what do you do?
I'm an RN. I work in Victoria Hospice and also in long-term care.
Great. Welcome.
Thanks.
Can we see the other participants? Or just you guys?
I think you just see us in this format.
Okay.
Yeah.
Sorry.
Okay.
Hi, I'm Sheila from Priori RN.
Hi, Sheila.
Hi.
Okay, we're 1 minute past the hour, so we'll just get started. We just start with introducing myself. I am Jillian. I'm the LTCI's program coordinator. I'd like to take a moment to welcome you to our LTCI Learning Series event on a palliative approach to long-term care. It is with great respect and appreciation that I'm speaking to you today from the traditional and ancestral territories of the Sauk Nation that I am fortunate to reside on. I'd like to run through a few housekeeping items. Please keep yourself muted in general, as background noise can amplify very quickly. There are CME credits available for this event. A member of the LTCI team will email you with a certificate sometime later this week. At the end of the evening, we will have an evaluation. Please take a few moments to participate, as your feedback is really appreciated. This event will be recorded and we will share that with a private link along with a copy of the slides to all of the evening's attendees. If you have any questions throughout the evening, please unmute yourself and ask away. We like these events to be as interactive as possible, and there should also be time left at the end for discussion as well. I would like to introduce our presenter for this evening, Dr. Amy Tan. We are very lucky to have her join us tonight. She has been a palliative care and family physician for 20 years. She is a clinical associate professor in the Division of Palliative Care and Department of Family Practice at the UBC Faculty of Medicine, and is an adjunct associate professor in the Department of Family Medicine at the University of Calgary. She currently practices as an inpatient consultant physician for palliative care as a long-term care physician on the Saanich Peninsula. She has numerous publications from her research in ethical decision-making, primary palliative care, culturally safe communication, and advanced care planning. After medical school at the University of Calgary and her family medicine residency at the University of Alberta, she completed a Master's of Science in Palliative Medicine at Cardiff University. She has extensive leadership experience in medical education as faculty of the University of Calgary, University of Alberta, and now UBC, particularly in communications, ethical decision-making, physicianship, primary palliative care, teacher assessment, and faculty development. Dr. Tan is also an advocate for health equity and an anti-racism educator and consultant. Without further ado, please welcome Dr. Amy Tan.
Thank you so much for the introduction, and thank you for the invitation to present. I just want to make sure, I'm hearing a bit of an echo on my end. Are you guys hearing an echo?
No, I don't
No,
hear
it's-
an echo.
Okay. All
Nope,
right.
you're good.
Okay. And can you see my slides is the next question.
Yes.
Yes.
Okay, great. We will get started. And as was mentioned, feel free to raise your hand or even just interject, because it's hard with the webinar series for me to see hands up, etc. And then I think I'm going to have help with monitoring the chat if there is any chat questions, and I'm hoping there's going to be lots of time for discussion at the end if there's any specific clinical questions, etc. So I wanted to just start with acknowledging that I'm coming to you from the unceded, unsurrendered territories of the Wasanich First Nations in the Saanich Peninsula area, for which I'm very grateful to live, play, and work here. And I am also very honored and privileged to work directly with the 4 Wasanich First Nations at the Saanich Peninsula Hospital to try to foster more culturally safer end-of-life care for Wasanich First Nations directly. I don't have any conflicts to disclose. The only conflict I have is that I'm a very, very passionate advocate for primary or upstream palliative care, and that might come out in this presentation. That's all I have. So the session objectives are going to be to discuss how to implement a palliative approach to care for your patients in your long-term care practice. I hear that there's different members of the allied healthcare team, and I hope it's relevant for all members of the healthcare team. Specifically, we're going to discuss practical aspects of advanced care planning, how to prognosticate patients, especially with our aging population, and the fact that most patients have more than one diagnosis, and they live with what we call multimorbidity or multiple comorbidities. How we go about just deprescribing or discussing that with families, and how do we, including deprescribing, how do we have care planning conversations with the team and the patient's family support. So I'd like to just start with a case just to kind of frame perhaps where we're all coming from. Like I said, I am a long-term care physician. I've been practicing in long-term care in addition to my consultancy, specialty, palliative care, inpatient work. And the reason why actually I love doing my long-term care practice is because 20 years ago, I used to practice in hospices in Alberta. And 20 years ago, the demographics were different. They were more cancer, not as much non-cancer, and there wasn't actually as much demand, to be honest. If I look back 20 years ago, or more than 20 years ago at the start of my career, and I had patients 6, 9, 10 months in hospice, and I formed wonderful relationships with them. Now in Alberta, in BC, with the hospice criteria being 3 months or less, and because of the increasing need of hospice beds, we're not actually able to really develop those long-term relationships with patients. And I've been struck in the last couple of years that really long-term care is now where patients are entering for the last chapter of their life. And we're going to talk about some demographics and some statistics, but that's really where I get the fulfillment from, doing upstream palliative care for what could be 18 months, 12 months, and patients are comfortable and familiar with their surroundings. And that's where I'm coming from in terms of really advocating for a palliative approach in the long-term care setting. So to start with the first case, we have Ken, who's an 81-year-old male who's been in his current long-term care for 38 months. He needs ADL supports. He has a medical history of major neurocognitive disorder, which is a mixed etiology, AFib, hypertension, chronic kidney disease. He spends his day walking with a walker for most, well, probably 50% of the time he's able to ambulate with a walker. The other times he's self-propelling with a wheelchair. And then he spends probably a third of his day in bed. He's able to engage in very direct conversations in terms of what he wants, apple juice, orange juice, whether or not he needs to toilet, whether or not he has pain. But his baseline is pretty pleasantly confused, not oriented to time or place. And he might not recognize the MRP, he might not recognize a lot of the nurses, but he can recognize his close friends that come and visit him. He's had some mild weight loss, which has been seen from his 1 year gap in care conferences, and that he's lost, you know, in the order of 8 pounds in the year. And there's been 2 episodes of delirium in the last 6 months. One day, unfortunately, he falls using his walker, and immediately he's screaming and is unable to weight bear, and is a shortened externally rotated left leg, and it's highly suspicious for a hip fracture. His MOST is M3, and you're called as the SBAR physician on call. What is your approach to caring for this patient and his presumed hip fracture? And I can maybe ask for a couple people if they're willing to share some of their thoughts right now. Whoops.
Yes, I'm David Clinton Baker. Can you hear me?
Yes.
Yeah, okay. So I'm a family physician who works very part-time in long-term care in Victoria. And if I was in that scenario, and it's M3, which has presumably been discussed with family at a care conference and confirmed, I would go out and see that resident in the nursing home, assess them, confirm the diagnosis, and then I would call the family and confirm that indeed that they do want an acute transfer, which the M3 would suggest. And I'm probably not going to get a good feedback from the resident himself, but I would call the family and talk to them.
Great, thank you. Before I ask a follow-up question, I'm going to ask if there's anybody else who's willing to share first thoughts on this.
Yeah, I would. It's Dale.
Hello.
I would do exactly what David did, and I would make sure they understood the likelihood of survival or not surviving. And
Okay.
generally speaking, in that context, people will, not always, of course, but oftentimes they will elect to keep the person in the home and be cared for.
So how would you, so in response to both, thank you for sharing, in response to both, you call a family or you call a friend who's the surrogate decision maker in this person's case, and they know this friend is well involved. It's you know, a well involved surrogate decision maker. Unfortunately, you're the on-call physician, so you don't have the relationship like the MRP would have. But the surrogate decision maker then asks the question, well, why wouldn't you bring him to hospital? Don't you do that when somebody's broken their leg?
In Broadmead Care, as I think you probably already know, in the 2023 fiscal year, we had 13 hip fractures with about an 80% mortality, 100% for people who did not have an operation, although we have had people survive months to years with untreated hip fractures. And of the people that did have a hip fracture, most of them succumbed as well. And hip fractures are a common event at end of life. And ultimately, the decision maker is going to be the one that makes the choice, but it's important that he understand the hazards of pursuing surgical repair.
Okay, thank you. Any other thoughts about this case? I'm using this as a scaffold to kind of hang our hat on, you know, the type of patient that we're looking at, and just making sure we're all on the same page in terms of the patients we take care of in long-term care.
Sure. Hi, Amy Tan. I was always of the opinion and belief that if you didn't repair the hip in somebody who might live for several months, it made the nursing care very difficult in terms of pain control, the comfort of the patient. So rightly or wrongly, in this situation, I have usually, with the most M3, encouraged repair of the hip for the comfort of the patient, as I say, rightly or wrongly.
Okay, thank you. So what I will say as a palliative care physician, if it's a pathological fracture with due to cancer, yes, surgical repair could actually remarkably help with pain relief, but in a traumatic non-cancer, the story might be a little different. And we're going to keep going on to the story of my slides, and hopefully that that point will be directly addressed in a bit. Is that okay, Rick? Is it okay if I call you by your first name?
Of course, yes.
Okay. All right, so we're going to carry on. So just to frame again who we take care of, I wanted to just explicitly kind of take a big bird's eye view of what palliative care is. There's the older definition, and by older, it's actually not that old because, like I said, I did my training about 22 years ago, and this was the definition of palliative care that I was originally introduced to palliative care with, which is that while there is concurrent symptom management and quality of life optimization, most of the focus at the time of diagnosis, mainly, and again, 20 years ago, was mainly cancer at the time of diagnosis, was to modify the disease or to cure the disease. And as disease modification options waned, or the disease progressed, and/or then palliative care would then take priority. And ultimately, it would lead to the patient's death, and you would have the end-of-life care being in the last, let's say, 3 to 6 months, and then bereavement care. Pippa Hawley, who many of you will know from palliative care in Vancouver, has proposed a more modern approach, which is the bow tie method of palliative care, which is really that no longer is it that we, do a 80-20 split, that really it should be that we concurrently are always thinking about symptom management and quality of life optimization and talking about patients' goals and the bigger picture at the time of diagnosis. And in fact, in Calgary, I did a research study with GI oncologists and palliative care physicians and family physicians, where we really tried to develop a pathway where at the onset of diagnosing a GI cancer, palliative care was involved right away. And what we were struck by was were patients and society and GI medical oncologists were taken aback at first by the notion that palliative care should be at the time of diagnosis. And so this is kind of like this reframing of palliative care. Palliative care itself is not a heralding of one is dying, although I would, again, just like to discuss and say that we have 100% mortality rate. So it's trying to signal that there's imminent dying, but that there is always an added layer of symptom management, psychosocial support, and discussing kind of what to expect that could be beneficial for the individual patient and their support at the time of what we call now a serious illness. So it could be a cancer diagnosis, it could be a serious diagnosis like MS or ALS. So it's no longer specific to timelines and specific prognosis. It's about, is this a serious life-altering, potentially life-limiting disease? And can we actually add an added layer of support at the time of diagnosis? So, this has been already alluded to in the case reaction, but just to kind of reframe in terms of who our population is again, the long-term care patient demographics in BC, this is from the 2023 Long-Term Care Assisted Living Directories report from the Seniors Advocate of BC, its office. And so most recently in 2023, the average long-term care person was 83 years of age. More than half is 85 and older. We have a small percentage that are under 65, and 2/3 about are female. Interestingly, the average length of stay in long-term care in BC is 2.3 years. That has been decreasing in the last year and decreasing since in the last 5 years as well. And I've seen this also in my practice that for some reason in health authority owned facilities, the length of stay is slightly shorter than in contracted or licensed facilities. And Vancouver Island, where I work, I think the average is actually less than 18 months now. But interestingly, 50% of all BC residents who live in long-term care will die in the first 1.3 years, or 488 days, but 1.3 years I think is easier to grasp. And if you look at data from across the world, pretty similar. There's a Danish study that shows in 2019 that 30% of their patients in Denmark, different demographic, perhaps different health status of the population, but a third of their patients died within 12 months. So I think pretty contiguous there. Also, I just wanted to also start with what the life expectancy in Canadian demographics are and compare that to BC. So the most recent I can get is 2022, and the average life expectancy of a person born today in 2022 would be 81.3 years. And unfortunately, our life expectancy actually has dropped in the last couple of years that we have data for, likely due to COVID. Just want to put that out there. But if you look at birth in Canada, so this is just to give you a comparison that if at birth, if your life expectancy is 81.1, BC was slightly higher. If you make it to age 65, you actually will have a life expectancy that will take you to just over 85. So just to kind of put that into reference, somewhere in the early 80s is kind of the average life expectancy of our population in BC. Any questions or comments at this point? Okay, just check the chat. Don't see anything right now, so I will keep going. So when I'm talking about what an approach, a palliative care approach to patients is, I really look at it as kind of 3 goals or 3 things that we should do, 3 steps if you want to call it, but they aren't just step 1, step 2, step 3. They really are a flowing spectrum of tasks that one should do as healthcare workers, and it's an iterative process as well. So it's not just one kind of hit at this and doing all of those things. It's actually continually having taking these things into consideration, continually having the conversation, continually planning with the team, and continually having the conversations, mainly with the loved ones and the surrogate decision makers, not to take away from the patients, but a large majority of our patients unfortunately won't have full capacity to speak, and that is quite different from my consulting palliative care practice where I'm speaking directly to patients for the most part. So the first thing is, as healthcare workers, we are human and we are biased, and we know that studies show that we, despite our experiences, are overly optimistic. We want people to live longer. We hope our patients are going to live longer. And so when we actually are asked and put on the spot to prognosticate, studies have shown between family doctors, geriatricians, oncologists, surgeons, that we overestimate prognosis. And so prognostication is really hard. It's more of an art than a science, but it also takes into consideration those subconscious human factors and the optimism we have and the hope we have that our patients are going to perhaps live longer. And maybe those are societal expectations we have that are ingrained in us as human beings living in society. And so to help the individual healthcare provider determine trajectory, prognosis, functional status, we need to look at, where the patient has been over the last months. And that's the beauty of long-term care is we get to know our patients over months. And so what was this person like in the summer, now that it's November? What was this person like the last holiday season? And so we can use those as signposts to convince ourselves of what their trajectory is in terms of their function. Are they less mobile? Do they need more ADL care? Had they gone from eating independently to now having to be fed, helped at meal times? We can use that to actually be able to signpost to ourselves where there's big changes, because in the day-to-day, it's hard to kind of notice those changes. We can also then describe those changes that we're seeing to patients and families. We're going to talk about how to use the illness trajectories to help them with prognostication. And then think about, again, is the patient competent to have these conversations? And if not, we'll have to talk to patients, family and loved ones and name surrogate decision makers, or in BC, the Health 9 representative. So this is shameless marketing. No, I'm kidding. This is my master's thesis, actually, that I did for my palliative care master's. And it was about talking to surrogate decision makers of dying patients. And my supervisor and myself, Dr. Menka, we developed a framework here illustrated here. But what the reason why I'm bringing this up is because even this was published in 2013, so 2011 when I got my master's, this statement that the physician's own internal conflict may impede in delivering consistent messaging to surrogates came out in the interviews that I did and analyzed. And so just kind of saying, like, don't feel bad that, prognostication is hard, because it's very hard, but also we're dealing with our own human instincts to want to be overly optimistic, but also we develop relationships with our patients, and we don't, it's hard to perhaps think or give bad news. So how do we maybe have some objective information to help with this? So the first tool that I'd like to share is this concept of illness trajectories. And this was first published, in the 2002. Again, I learned about this about my first 5 years of practice. So I actually wish I'd learned this earlier. And so, 100 years ago, people died differently. The large majority of patients actually had the first illness trajectory of sudden death, and be it because of childbirth, infection, which unfortunately with COVID-19, we saw the return of this trajectory. But between infection, childbirth, and trauma, most people had this type of thing where they were living, there wasn't any decrease in their functional status or health status, and they unfortunately passed away. The terminal illness prognosis is what one thinks about with a stage 4 cancer, where they're doing well, something happens, they are diagnosed, and unfortunately, there's a tail that then declines to death. It might not look like this as much with modern cancer therapies. It might be more a prolonged stage with a more step down and then a heralding event to death. But ultimately, the goal of this is to say it's not a sharp drop off, that there is warning, and that there is a more gradual decline in function and health to death. And then we have the patients who I think actually are the majority of the patients we have now in modern society, which is organ failure. And what you'll see is that it's up and down, looking like a seesaw. And this is because, for example, for COPD exacerbation, they have an exacerbation, there's a dip down, they get on steroids, they get on antibiotics, they go improve, and then they go back down. And we're going to delve into this one a little bit more. And then with frailty, one would say that this is frailty or dementia, that there could be, unfortunately, low health and low function for a protracted period of time, could be years, until eventually death. However, in our long-term care practice, we could have patients who might have an organ failure, might be on an organ failure track, let's say. And unfortunately, they could have a catastrophic event because they're at risk for that. So they could have a stroke, they could have a TBI from a fall, they could have a hip fracture from a fall. And what I tried to superimpose here was, they had the seesaw trajectory, and then they might decline. They might have they might fall, have a hip fracture. Depending on what happens, they have a marked step down, and then they unfortunately then have perhaps another seesaw another seesaw trajectory to death. But unfortunately, overall, the step down in health and function is quite marked at the time of the catastrophic event. And this is the window that I think we need to really, I mean, I think the whole place is a place for palliative care, concurrent with disease management and being on blood thinners and antihypertensives, etc. But I think this place here is very much calling out for us to see, can we optimize patients' symptoms management? Can we optimize patients' quality of life? What is important to them? How do we actually have that conversation with patients and family? And then we need to think about then, you know, what are we doing in that time? Are we prolonging life? Or are we extending dying? Are we delaying preparing for a natural death and the possibility of acceptance and closure? What are the costs that we potentially could be asking our patients and families to pay, really, with their lives, with lots of medical interventions? So just something to think about. As we drill down into the organ failure, one, I would also like to say with this illness trajectory is, while you could have up and down, I want to remark on the overall trajectory is still downward. And so what happens is, after an exacerbation of CHF, after an exacerbation of COPD, patients generally, especially in the last 1 to 2 years of life, will not bounce back to the same place they were at. However, patients and families often won't realize that. They will remember how terribly they felt. How terrible they felt, how sick they were, and then they felt much better and they were able to leave the hospital, for example. And so this is where, you know, being able to track over time, like, how was this person last summer? How was this person in the springtime when the cherry blossoms are out? How was this person last holiday season? That helps broaden the picture and helps patients and families understand what potentially is happening in the larger scale. The other thing, though, I wanted to mention is how many people have now one end organ disease process going on. Most of our patients have superimposed trajectories. And so it just makes it that much more muddy, that much murkier. But also, I would say, you know, it just really shows how much stress the body's going under. And so with every exacerbation, it's going to be actually more of a drop off. So that's the first, that's really the first set of tools that I want to help to give is I actually will draw out illness trajectories in my care conferences when I'm explaining dementia or I'm explaining COPD, to help families understand what I'm seeing, what the team is seeing, and comparing it to what they're seeing, but also to describe what I'm seeing in terms of perhaps a functional decline, especially over the last year. Another tool that we can use is the clinical frailty scale out of Dalhousie University, Canadian, in Halifax. I have to admit, I'm not a huge fan of the graphics because I am actually a disabled physician who uses mobility aids in my daily life. So I find that this is a little bit misrepresentative, but use the descriptors for, you know, how dependent a person is for their care, whether or not they're stable, whether or not there's, you know, instability, that, you know, there's calls to the SBAR doc ongoing. And clinical, you know, the clinical frailty scale of 6, 7, 8, 9, that really actually is our population. There's very few that are, you know, I would say when I was doing family practice, there was some in their 4s and 5s, you know, elderly population, but when they're in long-term care, they're quite frail. However, patients don't perceive their frailty. And I will just give you a little anecdote in one of the studies I was doing, we actually tried to identify frail patients in family medicine. So people who are living at home and coming in for their prescriptions. And we gave patients this clinical frailty scale, and we asked them to rate themselves. And patients that their family physicians would rate as 4 or 5, they were rating themselves as 1 or 2. I share this with you only to show how perhaps there's misconceptions and misperceptions about how well a person is. I was very struck by that in terms of the results of that study. But I also think that it comes to bear every day that I talk to family members as well, that they also have an overly optimistic view of the reality of their loved one's health. So the point of me telling you about these tools is really to show you that tools exist, not to become experts in using these tools, but really to say that there's tools that exist. And what are the general Gestalt parameters that we use to look at a person's health and functional status as it relates to a serious illness, as it relates to overall prognosis? So we have illness trajectories, we have clinical frailty scale. This one is really about hospitalized patients and looking at unmet palliative care needs. But you'll see that whether or not a person has cancer, dementia, neurological disease, a serious illness does then speak to having unmet palliative care needs. And that's really the takeaway from this, is that if they have a serious illness or comorbidities, again, that should be a sign to actually be having these conversations with patients and families and thinking as healthcare providers, what can we do to optimize quality of life, comfort, and how do we actually talk about what is to come in the future? We sometimes have patients who are M3, C0 most, and they might go in and out of the hospital. Maybe there's a patient who's been in and out of the hospital for 2 or 3 times in the last year, or now, unfortunately, is not able to wheel themselves, self-propel on their feet, and are spending most time in bed. Maybe they're losing weight. These are all indicators that maybe we need to be thinking about how do we incorporate a palliative approach to care. We can also use the palliative prognostic index, which is the palliative, using the palliative performance scale, which I have later on, so the PPS that's out of Victoria Hospice, and then whether or not they're eating less, whether or not they have edema, whether or not there's dyspnea, and whether or not there's delirium. So again, it's not so much like knowing how to score right now. You can look this up and you can score, but it's looking at the parameters, the things that we look at to prognosticate. And what the appendix in this prognostic index said that there's clinical indicators of decline for patients with end organ failure. And that is, for those with only weeks to many weeks of life left, it'd be poor performance status, decreased nutritional status, and a low albumin level. Very relevant to our population in long-term care with dementia. There is the mortality risk index score. Again, what are we looking at? We're looking at whether or not they have congestive heart failure, whether or not they need oxygen, if they have cancer, if they have dyspnea, are they eating less? So again, you're starting to hear a repetition of the things that we see as they start to come up or drop off. These are things that we should be thinking about as a team. Okay, what is our approach here? Does the family know? Do we have a plan? What is happening with our patients, and how do we plan going forward? Do we change things? Do we come off blood thinners? Do we maybe urge a change in code status, a most designation? So these are the things that we should be continually and iteratively thinking about. For patients that perhaps come to long-term care from a hospital admission, I think a lot of our admissions do come from acute care. So the Homer scale is a good scale because it talks about their hospital admission, from which they were transferred to long-term care, and their 1-year mortality rate having been in the hospital for that admission. And again, it's not about the details so much in the scale, but to show what are the Gestalt points. Oxygen use. Were they admitted to the ICU? Did they come by ambulance? Do they have a significant serious illness with the diagnosis? The Charleston, this is the Homer score uses the Charleston Comorbidity Index score, which is actually a disease-related score, and then embeds it as points in this score. So it's actually quite precise because it incorporates another scoring system into their scoring system. Whether or not they're living on their own before, whether or not they had an ambulance come in, all of these things are taken in. And this was, this was published in CMAJ. And if you look it up, CMAJ and Homer score and the mortality risk, you'll see that it will tell you the 1-year mortality based on the score in there. And so this again can be relevant for especially those patients who might have returned from a hospital during their long-term care stay or been admitted and transferred to long-term care as something that we could use to convince ourselves, but also, and what I mean by convince is really to understand the reality of the situation so that we can then more confidently discuss this with patients and families. So when I say performance status, when I say functional status, I'm really talking, how much care they need, self-care they need. Do they need to be fed? Are they eating? Are they needing help with toileting, help with ADLs? Are they able to ambulate? Most performance status scores, again, use the same parameters. And then the Karnofsky score and the Palliative Performance Scale are ways that we can just kind of cogently bring it together and come up with a number. When I talk to teams on the phone and I haven't maybe laid eyes on a patient, I will ask the PPS because it just gives me a gestalt image in my mind of kind of where the patient is. A patient with 50% PPS is going to be very different than a 30%. It's going to be very different from 20 or 10. And so it just helps me know where I'm starting from. Any questions or comments at this point? I see there's some chat activity, but.
Maria, just go ahead. You don't need to raise your hand.
Oh, hey. Hi, this is Cleo calling from the Vista. Now, I know that we do have these in place for when they do get to that point in their disease process, but is this something that we could actually have a discussion with the family in the beginning? And then instead of waiting until they get to, or they have a crisis or an injury of some sort that puts them here, can we just do it as care conferences? Like, where are they at now? Or is that something that is good? Is it good to start placing that in people's mind? I am all for that, but is that something that should be done more in practice than, is it too grim?
Yeah, no, so I very much incorporated my care conferences as part of my practice. And you'll see in the steps, educating the patient and family is very, and mostly family, let's be honest, is where I'm at. So every care conference I really do, I frame it as, let's go over the most again, but really it's about, this is what I'm seeing. And sometimes I don't, it's like, even a patient with M2, I don't need to change the most. It's really about, this is what I'm seeing in the last year. And I actually find the care conferences is a very natural signpost. Like a year ago, we talked about this, and now we're talking about, the fact that he needs to be fed versus him eating independently a year ago. So that is a significant change in what I'm seeing in his functional status. And that makes me think that, his dementia is progressing. So I really do advocate for having these ongoing conversations with families. I will admit, as a human being, as a physician, as a palliative care doc who's very passionate about upstream palliative care, it literally hurts my heart when patients' families tell me that they're surprised their 91-year-old patient, loved one with dementia has suddenly died. because we know it's not sudden. And so then, when that happens, I take that as, yes, how much was absorbed of what was discussed. But even with conversations, they can feel that. So without conversations, it can only be worse. And so I think, especially with our long-term care patients, I feel strongly that we have the opportunity, again, with the ongoing longitudinal relationships we have, to be preparing patients and families for what is to come. We started with the statistics, like the statistics are there, in terms of 50% of BC residents in long-term care will die in the first 1.3 years. And I think, I think we owe it to our patients and families to prepare them and discussing it on an ongoing basis. I think for most people, it makes it less scary.
So I began.
Absolutely. Oh, sorry.
The dangers of not having hands up. I'll just be a second. I have this conversation with decision makers on the day or the day after admission, either face to face or on the telephone. I virtually get everyone to go for a most of M2, discussing the communication, the importance of communication. I talk about the life expectancy across the country being 18 months after coming into long-term care. I talk about the inevitability of falls. I talk about the hazards of medication, and most of the time, not all of the time, but most of the time, I can get medications down to a very low number. And I talk about what to do in the event of a fall with a fracture, and I explain the risks of all the things I was talking about earlier. And I don't use any tools, and I don't know how long a person is going to live, but I can certainly say whether they're going to be, their future is more restricted than perhaps it was a year before if we're having care conferences. And there's no way of knowing anything. And you've also got to look at what is palliative care. The medicine has become a business, and that's in part because of the way we are taught and the need that we have to do things all the time. But we don't have to do things all the time. And there's lots of people in my former practice who thanked me for not doing this, that, or the other. And I extend that to the screening programs that exist as well. So personally, I don't engage in any screening programs at all. I try to take care of myself. I try to keep physically active. I keep my medication consumption to a minimum. If I get a cancer diagnosis, I'm going to go tits up. I'm not going to go and pursue treatment. So I guess I'm palliative care.
Yeah. So, and so, I think all that information you share is really, really important and really good at the very beginning of the admission. I think for the average person living their lives, it might be a lot of information, and so that iterative, repetitive, ongoing conversation might be important. And I actually will say that, I've been doing this for 22 years. Advanced care planning has been kind of my raison d'etre. I've been doing research in this since 2006. I used to actually come at this thinking that if I didn't appropriately convince a family to be, this is before most, so like a DNR or not transfer to the hospital, that I was personally failing. And I think part of, the humility in being a physician is we need to meet people where they're at as well. And so you might not change the first conversation, you might not change their most, even if medically it's appropriate that they're more an M2 versus a C0 or a C2 even. But if you start the magic's in the conversation. If you start the conversation, then the next time you then carry them in their understanding a little bit more. And eventually you hopefully will come to a common ground where the most status both exemplifies what's realistic medically, but also with good understanding of the patient and family as to what is realistic and why and where they're at. And that really is the hope with shared decision making, that we get there. Sometimes it can't be in one conversation. Sometimes it has to be over time. And again, I've learned over 2 decades to, realize that we need to meet people where they're at. Sometimes deprescribing can take 6 months because we need to help patients and families where they're at. Maria, you had a comment as well?
Sorry, my question actually was just, what is the standard tool that we can use? Because I would like for my staff to just be really present with this and understand what they're going to be looking for. And I understand that there is a lot of, with the performance status here that sometimes is good and then they seesaw and then you go back and you go forward. But
Yeah.
I want them to understand that this is the tools that we're going to be using. And I would like to, and correct me if I'm wrong, but I would like to have it where on admission or on move-in, we visit this. The doctor will speak to what what the disease process looks like. And then in the next year at the next care conference, we have something to compare.
Yeah, and I think, you know, all.
But I
all
just want to
these
make
are-
sure that I'm using a standard. Mhm, mhm.
Yeah, and so I was just gonna say, I mean, the next part of my slide is this, if I can, you know, with the PPS for cancer patients, there is some prognostication data. This is actually out of BC as well. And you'll see that a PPS of 10%, there's a 50% survival rate the first day, and 98% are gone within 14 days. The longest in 22 years I've had of an actively dying patient at PPS 10% was 13.5 days. So, you know, that tells you where they're at, but this is for cancer patients, which is more validated. But if you look at data out of the UK, which is old from 2012, if you look at the survival median time for malignant, non-malignant, and dementia patients, the survival was 3 days for 10%, 35, so just over a month, 35.5 days for 30%, and 52 for 50%. So that's actually striking, I think, because I think a lot of our patients are 50%, and I would argue that families would be quite surprised. And I've actually been struck in long-term care that patients actually will die quite a bit quicker than patients who are younger with cancer, for example, who are the more traditional palliative care patients in acute care. So all this to say, I can't really give you one tool and say this is the tool that's going to give it all, because this is really my slide to say there's lots of tools out there. There's no perfect gold standard because everybody's different. And I actually would say that in a long-term care setting, the illness trajectories are probably the most helpful. And so it's really being able to depict one's clinical gestalt or gut feeling. And I guess the other one, which we know is actually which is really not a good question, and it's been not validated because it's poor, is the surprise question, which is, would you be surprised if this patient were to pass away within the next year? It seems to have some favor in that it's easy, but it's actually not that accurate. And so that's why I would actually argue that you need to use 2 or 3 modes to be able to triangulate. But if I were to choose one, I would actually be using the illness trajectory in a long-term care practice with the benefit of longer months relationship, being able to track patients functionally, medically over time, I think will give you more of an indication. If they're declining on a day-by-day basis, their prognosis is likely days, even with non-cancer patients. I'm sorry that's as clear as I can be, Maria.
That was absolutely perfect. Thank you.
Okay, thanks.
So Dr. Chan, there's a couple more questions chat
Sure.
there. Yeah. Ria's had 2 questions. She wanted to know why more women or less men in LTC and in palliative care. And then the second question.
I don't know about that. Like, so I didn't write that paper, so I can't delve into the raw data. I think if I look at just kind of with all of my hats, and I think that there is some gender roles in society, I think, playing. I think men especially the patients I see, they can be more reticent to ask or receive help. Even like palliative home care has been a challenge in my palliative care practice to have patients even want to go home palliative home care, for example. This is all anecdotal. I haven't done a study on this, so I don't know. But then we also have like as patients age, we have a larger population of widows. And so there are patients who husbands have died and they are now in care. And we know that women on average do live a little bit longer than men. That's statistically backed up. How do we close the gap between patients' score at 1 and physician's assessment? So yeah, so again, I think it's using illness trajectories. I think it's not trying to be doom and gloom, but trying to be painting a picture gently of what you're seeing and perhaps why you're concerned, and what you're worried about as their healthcare provider. Like, I'm worried that your fall risk has worsened. I'm worried that, you know, your safety as I observe you walking with your walker is actually less and less. So, you know, sometimes you bring it on yourself and you say, I worry that I'm seeing these changes and I would like to share them with you. But it really is, again, having those conversations of what you're observing. I'm trying to paint a picture for patients and families. Well, is there another question?
There's just one comment in the chat.
Okay. Okay, so I'm gonna go on if that's okay. So once you have taken stock of where your patients are at, you've talked to the team, you know, you're all on the same page as to what you're all seeing. Then it's about talking to patients and families. And again, I'm not trying to cut out the patient anyway, but the reality of our long-term care population is that, you know, the vast majority, unfortunately, do not have the capacity to have these conversations because these are high executive functioning decisions. It is not the same as saying, do you want apple juice or orange juice? And they can tell you. It's higher level weighing of pros and cons, putting into perspective one's values and goals and how they perceive life and quality of life. Those are all higher executive order functioning. And the first thing might be just helping family members understand that, in fact, they are up to bat now as a surrogate decision maker, that we actually need to talk to them and they need to make decisions. Patients, families, for the most part, really, again, have an overly optimistic view of perhaps what the patient's capacity for decision making is. But there's also, I think, this gut sense of like, I don't want to have to make a call for mom or dad, or I don't want to make a call for my loved one. So again, it's supporting the surrogate decision maker and empowering them to actually enact their role that was bestowed to them, either by the law, but hopefully by the patient, because it was discussed as who was the SDM beforehand. And I can go on an entire different tangent about why we need to have more of an awareness campaign for people to identify the right SDM. But let's hope that people are having those conversations about who is the most appropriate. It might not be the firstborn, it might be somebody who has a better temperament to do so. It might not just be the person who's in medicine. There's lots of other reasons why a person might be the best surrogate decision maker. Because once you have those conversations, you can then start talking about the signposting, start talking about the look and the functional loss. And then you talk to the patient's families and SDM about what the patient's overall goals in life are. And so, you know, the question about, is this too doom and gloom to talk about in care conferences? I actually really emphasize the living. What can we do to make sure we're living? We're doing what is desired for the patient in living. Talk about trade-offs and costs. Talk about how do we actually, you know, how do we actually ensure that the care team are all on the same page to ensure that we are doing right by your patient, right by your loved one, in enacting their values and goals. So going back to the hip fracture and having this conversation, if you're calling the patient's family and you're like, you know, I think Ken broke his hip, what would you like us to do? You know, and M3 is a starting point for a conversation. It is not etched in stone. You do call the family and you say, you know, this is where we're at. And Ken's surrogate decision maker goes, well, of course you bring him to the hospital. Why wouldn't you? And this is a study you could use to maybe say, why wouldn't you? And so this was a study that was done in 2022, so very recently. And it showed that for the postoperative versus the operative management of patients with dementia and frailty in long-term care, that the first 2 weeks post-op, there wasn't actually much difference in pain management. That the pain management was similar for those who were operated and not operated. They both needed opioids for that time. But the adverse events were higher and more frequent in the operative group, such as need for antibiotics, blood transfusions, another surgery. And it was in the order of 68% in the operative group versus 46% in the non-operative group, and that was statistically significant. And the 30-day mortality, though, this was the difference, was the 30-day mortality for the non-operative group was 83%. And in the operative group was 25%. So the first 30 days, there was definitely a higher mortality in those who didn't have surgery. However, if you look at the 6-month mortality, it was 94% in those who did not have surgery and 48% in those who did have surgery. But the median time to death was again, within the first 30 days for both groups. And if you look further, this study actually looked further and talked to the proxies and the surrogate decision makers and asked them to reflect back on the deaths of their loved ones. And the non-operative group had a majority say that they had good to almost good to perfect death. I'm not sure what a perfect death is, to be honest, but good to almost perfect death, majority in the non-operative group, versus the majority in the operative group had an intermediately good death, so lower. So these are all things to think about in terms of when we look at functional status in a patient. This patient is a real patient of mine, has severe advanced dementia, is not oriented to time and place. What is quality of life as defined by him? What is important to him? These are all the conversation and questions that we should be asking surrogate decision makers, because this is all important to the individual. And there was a comment like everybody's going to make a different decision. Absolutely. But we will not know until we ask. Some people are going to say, I want to extend life at all costs. Some people are going to say, I want quality at all costs, including shortening my life. It's not a value judgment on anyone. It's to ask and be, upfront that people are going to be different. I wanted to take this opportunity. This is hot off the press that in Island Health, at least, there's now a clarification of M2 as of October 8th. I actually support this. I wasn't part of this decision, but I support this. In that M2, there was some confusion with what M2 meant. I think in long-term care, it's actually fairly clear. In a standalone long-term care that is not connected to a hospital, even by walls, maybe not systematically, but doesn't have outpatient access to labs or X-ray easily or CT scans even. I think for us in long-term care in a standalone long-term care facility, it's pretty clear that M2 means don't transfer unless you really can't manage patient symptoms. But in acute care, M2 has really meant an overly invasive approach in practicality. And so Island Health now has clarified this is a less invasive approach where we're really trying to promote day-to-day quality of life with less without intensive tests, shifting away from invasive medicine towards symptom control, allowing for death acceptance, closure, and demedicalizing the dying process. So I welcome this clarification because I think, especially in long-term care, it's quite clear, but I just wanted to use this opportunity to just say that this is, I think M2 has been for us in long-term care not to transfer, but to be explicit about what it is we're actually doing. So when somebody says, why would you not bring Ken to the OR, we can talk about that study, but we also can say, you know, he can stay amongst people that he knows, even if he can't recognize them, he feels safe here. He's been here for 33 months or however many months it's been. This is his home. We can keep him comfortable. We know him. We can read his nonverbal cues. He won't be scared being in an acute care hospital, perhaps having delirium risk, and he can be made comfortable with pain meds in a familiar surrounding for the end of his life or for the rest of his life. In the interest of time, I'm just gonna, I had some extra stuff on M2, but I don't think we need to go through all that. So, so then the last part is we had that conversation, and then once we do that, sorry, I apologize. This heading should have been talk to the SDM and care planning. I don't know how that got changed. So the last step is really going back to the family, shared decision-making. How do we talk about no further transfers to hospital? How do we come to why most M1 or M2 is most appropriate as per palliative care approach? Reassuring the patients and families, really the families that we're going to manage their end-of-life symptoms, reassure them that we are going to care for them in their home with people that they know, not put them at risk for delirium in the emergency department or hospitalization, or get, you know, hospital acquired pneumonia or COVID or something. And then also this is the time to actually then start to talk about death acceptance and, you know, closure, and what's important, and maybe there's a birthday coming up, and what can we do to make that really important? The holidays are coming up. If that is reasonable to think about, is there something we could do to kind of make the holidays really special, even though it's poignant because it's perhaps the last one? And we also can then have the opportunity to talk about culturally safer end-of-life practices. What's important to the patient and the family, their cultural beliefs, their religious beliefs, and how do we actually incorporate that in their place of living in the long-term care in their community with the staff that know them. And so when you look at all of this, really the palliative care approach is much more communication than drugs and medicine, much more education, de-prescribing. So I'd actually say, yes, we do give medications for symptom management, but a lot of it is okay. If we're taking a palliative care approach, then, you know, are we going to actually need rigid blood pressure control if we're not looking at 5 to 10 years prevention of stroke or heart attack? Are we going to need to really not give our 100-year-old grandma apple juice if that's what she's asking for, even if she has diabetes? Like, are we really avoiding anything in 5 to 10 years by strict sugar control if we don't need to? So this is part of like what is important to a patient, acknowledging that they're perhaps in the last chapter of their lives. What is most important? We are taught in medicine to prescribe. We are very seldom do we get taught to de-prescribe, and it's okay to take away medications. Why is a 100-year-old on a cholesterol medication? Like, these are the things we could do if and say, you know, these are not a benefit. Why are we increasing pill burden and delirium risk in patients when it's really going to not help them? Because 5 to 10 years for a 99-year-old, 95-year-old. And I have the eldest person I've had is 105. So this is all real for me, is, you know, we're not going to benefit them with Lipitor at 105. Education, really important to then help with advanced care planning and most. And if we're looking at a general tool, once you convinced yourself and the family, is using the serious illness conversation. For those of you who don't know about the serious conversation guide, it's based off of Atul Gawande's book that he wrote about called Being Mortal. And this was, so Atul Gawande is a surgeon, his father was a surgeon, and it was about his experiences with his father dying and how he was struck by how aging was medicalized and institutionalized, and people were not talking about what was important to them. And so it was a surgeon helping navigate the impending death of another surgeon, and really showing the humility of how, you know, us in medicine, we're not good at this. And this is just to show, like, I met him in 2016 when I was trained for serious illness conversation. And so this is, I think, seminal to, I recommend this to patients, I recommend this to healthcare providers, just to kind of talk about what it is that's important. Because the serious illness conversation guide was then taken by a psychiatrist at the Dana-Farber Cancer Center, who worked with Atoga one day. And this has now, there's like 7 iterations of this now. And out of Ariadne Labs out of Harvard. And so this has been tested, the language has been tested with patients. It has been validated in different ethnicities and communities. And I highly recommend that using some of this language, like when I first started using this 10 years ago, or just under 10 years ago, I would actually verbatim, and they actually try to get you to do this in verbatim at first. Now I really use the questions that I really find the most bang for my buck, which is, how much are you willing to go through for the possibility of more time? I use that in my palliative care practice directly to the patients. I use that with families for my long-term care patients. How much would your loved one want to go through for the possibility of more time? What's important to them? I worry that you're getting weaker. So this is the language that I would highly recommend you take a look at. And if you want, you can actually get some training in it with the BC Center for Palliative Care. I'm not directly affiliated with them now. I have done studies with them for the SICG, and I have contributed to some of the training modules. But I'm just putting out there for this website, would recommend, if you wanted to join a community practice or know more about how to institute this in your practice, to know more about that. So I do want to leave some time for questions. So I just wanted to say the reminders, really, again, the palliative care approach is about signposting and knowing where a person is at, especially with the long-term care practice. And so once you've shared with circuit decision-making bodies, whoever they are, then it's really, okay, does the most reflect the reality of the situation and everything we've talked about? I often say that the most to families is really a way for all of us on the care team to be on the same page as a starting point. Nothing is written in stone. I still get on the phone and talk to patients' SDMs and say, this is what we talked about. Do you remember we talked about this? I'm just confirming in the context of a fall, or I'm just confirming in the context of respiratory distress that this, in fact, is what you want. And so I find that the more we invest in those upstream conversations and education, the less we have crises down the road when push comes to shove. And hopefully we have more patients dying good deaths at home in their long-term care facilities. And I'm unabashed in my passion to help with that for my patients and families. And so you can use the Serious Illness Conversation Guide to talk to your family members, talk about the functional state, talk about the healthcare realities, what dementia looks like, what COPD looks like. Bring those together with a recommendation for, this is what I think is most realistic medically, but also in keeping with making sure we take Ken's values into consideration, that he would want to be surrounded by people who know him. He would want to be comfortable. He wouldn't want to, he wouldn't want to go through, I'm just making this up, but like he wouldn't want to go through a lot of pokes and prods for the possibility of a little bit more time. He would want to be comfortable at all costs. And I've also been struck in care conferences, again, though, we have to meet patients where they're at, and we have to meet family members where they're at. But I've had to go so far as to say to some patients and families, even if we keep you a C2, in no way does that impact the reality that this patient will not survive CPR, will not perhaps be revived to the same functional status that they were at. And really, again, we're talking about what, it's not just whether a person is going to be able to be revived from CPR, which in the elderly patients in long-term care, I would argue very, very few would. It's more that what's their functional status if they were to survive. And with the elderly, frail population in long-term care, they would most certainly not bounce back after if they needed CPR. And we know that, I mean, I can go through stats about that, but all comers, 6%, 6 to 12% all comers who survive, and a third will, and this is all comers, so this is not just for elderly. 6 to 12% survive a sudden cardiac arrest and CPR, and a third will pass away shortly after. Sorry, of the people, a third will pass away shortly after, a third will require much more care needs, and a third will be somewhat back to where they were. But again, this is including young people who have had cardiac arrest. And just my tidbit for most designation conversations is, remember, this is not a menu for if this happens, do you want this? Look at it from a broad perspective of what is important, what are the goals, and do the individual decisions then help us attain the goals? We do not have crystal balls. We do not need to say, in the event of a pneumonia, do this, in the event of a UTI, do this. It is about what are the goals that direct our approach to care for this patient.
There are a couple questions in the chat if you want to
Okay.
take a look, just 2 of them there.
Could you please include the SIC revised for long-term care and Fraser Health next time? Yes, thank you. And again, I wanted to just bring the screenshots to show that it wasn't so much the tool as much as it was the language that we need to use. Do orthopedic surgeons agree with Island Health clarification? I don't know. I'm sorry. I don't, again, I was heavily involved with the most designation with AHS in Alberta. I'm not involved at the system level in BC, so I can't speak to that.
Looks like Sarah has a question as well. Sarah Polovich.
Hi, thank you. I'm actually coming in tonight from Abbotsford. I'm one of the family docs out here who now is doing long-term care exclusively. And I'm always interested to talk and listen about advanced care planning, because what I have found, like being a parent, I'm constantly reinventing myself as a physician in long-term care, because, you know, sometimes I find how I talk about the most, sometimes I seem to hit it really well and other times not. So I'm constantly adjusting. And I really appreciate some of the comments that you made. And I can really relate to the one that you said where you no longer think it's your mission to make people change their most. I have found, I don't know what it's like over on the island, but around here, sometimes I find there's too much emphasis on the most, where I find people aren't talking to residents who are capable of talking about what their wishes are. So the other comment about how much people change in a year, you know, sometimes it'll be a year since I've talked about the most, and now we're in a situation where the person has declined. Maybe I haven't connected with the family recently, and now they're quite sick. And I do find those moments where they are sick and you're calling them as a physician that they know and trust, I do find those are those really special times where you can really have an impact, and people can feel really good about the decisions that they do make on their loved one's behalf. Because as you said, you can't predict every possible scenario and what you're going to do with it. The last thing I just want to emphasize is that I don't know about on the island, but I have found since COVID, families are less trusting when they come into long-term care. And I find a lot of them have had their loved ones at home for a long time. They've interfaced with the healthcare system many, many times before they finally get into long-term care. They've often been in the hospital for prolonged hospitalizations and have had really challenging experiences there. And so I find sometimes it's you really have to have a little bit of time to build the trust with them, for them to believe that you are actually there really caring for their loved one and wanting to do what's best for them before you start talking about, we're not going to treat this and we're not going to treat that, which is how I find some of them interpret it. So sorry, that's so long-winded.
Yeah.
I was saving all of that.
Thank you so much for sharing your experiences. Yeah. I think it's, I think we shouldn't have a scarcity mindset. It's not a zero-sum pie in that we're not treating something. It becomes, what is the goal of our treatment? If we don't give the person antibiotics because they can barely swallow, because we want to decrease the risk of aspiration and make them more distressed, we're actually trying to make them more comfortable and use other medications so that they're comfortable. So, and again, it becomes, the more conversations we have about this, the more we normalize this, the more we educate with the individual family, with the individual patient, but also culturally, I think there could be a shift. Lalji, is that how you pronounce your name? And do you have a question?
Yeah, thanks. My name is Lalji Halai, and I'm here in Burnaby. And I just wanted to mention my long-term care patients are in New West, and we had a discussion with the orthopedic surgeon about hip fractures a couple of years ago. And there were two schools of thought in orthopedic surgeons as well. Non-operative versus operative. So they're moving towards non-operative management in patients who are long-term care, who are elderly and frail. And they recommend that you'd rather keep them in the home, and just they would give us the reassurance that it's safe to do that. I think the more reassurance we need is for the nursing team and how they can manage the patients when they're handling a fracture.
Yeah, and that's why I really like that study, because it really actually shows us for non-pathological, non-cancer related hip fractures, the pain control management was similar in post-op versus non-op. And so that, I think, actually helps patients. I think that could help us kind of convince that there could be more adverse effects with surgery, and that generally a frail elderly who has a hip fracture in and of itself, that's actually a symptom of frailty and perhaps declining health overall, that it's not just the hip fracture, it's the hip fracture in a complex body system. So while we're talking about orthopedic surgeons and M2, I do want to say there was another person who asked about M2 and orthopedic surgeons. So I will say, in the cancer-related pathologic fracture patient who does get a pin because of exquisite pathologic pain, which I think still there's merit to, at least in Calgary, like I said, when I was involved with the system level conversations with most, there was a push for us to have to change our M2 palliative care patients to like a C1 or C2, like the equivalent, in order to get post-op ICU care. And I think it was shifting to, you could be an M2 asterisk, required hip fracture for symptom management. Go to the ICU for a day or two, be supported, extubated, and come home. And I've had a few patients at home and in hospice who fell and had to do that. And, they had 4 or 5 months of really good pain control that after bisphosphonate, morphine, sedation, I could not manage their pain.
I'm Dr. Avinashi calling. That I have one comment and one question. The orthopedic question was mine as well, but the comment is that each patient is different, each case is different, each situation is different. I think you have to involve the family and the patient if possible, if he is has no severe dementia, and then decide about each patient. And
absolutely.
Yeah, and and that's the one I comment. I put it in the chat box as well. My question is, what do you do with the patients who are M2, and I know they're not going to do very well, but the family insists on sending them to the hospital? What do you do then?
You know, we're all we try our best. We really, you know, there's patients families where I've had to be quite firm and quite blunt about how concerned I was that their risk of delirium because of their end-stage dementia or their fear was going to be worsened, and they were not going to benefit from going to the emergency department. 20 years plus of doing this on a daily basis, and there's going to be the subset, I don't know, 2%, 3% that are going to want to, and you have to abide by that. Again,
even if you explain it to them and they insist,
yeah.
I don't stop it though. I just let it go.
No, you know, I feel, and there's lots of reasons for that, right? There's cultural reasons. There's you know, I've come to really understand that there's some people who, and I've said this to team members, and I've said this to residents and medical students. There's going to be some people who really believe and really need to feel like they have done everything that is offered to them, and then they can rest. And then at some point, unfortunately, the body will declare itself. That's actually still quite the minority, but yeah, there are going to absolutely be exceptions. It's the flip side and the danger, and why I kind of profess this is that if we don't have those conversations, many people actually would not choose that. And I have, you know, been struck over and over and over and over again by the number of patients who will say, if only I had known, I wouldn't have consented to X, Y, Z. And that's the population that really motivates me to do this work.
Thank you.
Thank you.
There's a couple more questions in the chat if you have time for them.
Okay. Pain management for hip fracture, yeah, strong analgesics, but and for pathologic fractures, it would also be bisphosphonates and perhaps DEX, which doesn't help with healing. But yeah, so for pathologic hip fracture, it can be very exquisite pain that's multifactorial. For non-traumatic hip fracture, it's actually, yeah, a little bit of hydromorphone, and you can make them comfortable quite nicely. The overestimation of survival time is unfortunately reinforced during hospitalization. How do we close this harmful gap? Any projects on the go where long-term care and acute care meet? So specific to survival in terms of where long-term care and acute care meet, because I was part of a national study on implementing the serious illness conversation across Canada, and it was acute care, long-term care, and family medicine primary care. It was called ICANN ACP. If you Google it, our website should still be up. Our grant was up in the middle of COVID, or like the first couple of years of COVID, in the thick of it. But we have and there's a couple of studies that, we've published a few studies, and we continue to publish even though the grant's been up for a couple of years. I can provide some links to Sunita if that would be of help. In terms of closing the gap, again, I think it's a cultural shift. It's a cultural shift in medicine, and it's a cultural shift in society. I think the book Being Mortal really helps frame this, like what the big picture of I often use this phrase, there's many things we can do to a patient, but what are we doing for the patient? And I think we societally, in a death-denying, invincible society, and in a medical culture that really emphasizes do, probably because of legalities as well, and fears of legalities, is we need to take a step back and go, what are we doing for the patient? What is this medication, this intervention, this test? What are the costs for the patient, be it a transfer, be it a painful transfer, be it a risk of delirium or a fear because they're confused and they're going to a place with lots of bright lights and ringing and dingings and stuff, and what cost is that of that is? Do we have to sedate them to put them through a CT scanner for not having to see if there's a cancer for which we will not give them chemo because their performance status is so low that they won't actually be offered chemo? What are we doing for the patient? Lots of things we can do to them. And I think we need to really start to re-emphasize that and really be explicit in our conversation with team members and family and the public about this.
Dr. Tan, if I can just mention.
Yeah.
Lodge again. I wrote about the prognostication tool earlier on, and this was developed by Amber Jarvie, Dr. Amber Jarvie, and Belinda Robinson. You might know her. She's a palliative care physician, Dr. Robinson, in Fraser Health. And I can share with folks, provided Amber and Belinda are okay with that, if anyone would like to see that tool, the prognostication tool. It was mainly made for family physicians who are in long-term care to help them understand why CPR is not helpful, and there's statistics mentioned there. And I think it can be very helpful for people who want details. Like, there's some families who want to know the numbers. To explain to them that why CPR is not good, why this is not good. That could be a helpful tool to use.
Yeah, thank you. If you're able to,
I'll put my email, and
okay,
the division can contact me directly.
That'd be great. Thank you so much. So again, the question, do you have an approach when a committee or person is adamant C2 despite ongoing decline? Again, if you asked me 20 years ago, I would have said, we're failing the patient and family, and now I have some humility, and I say, try your best, give them whatever information it is. Some people want data, some people want the statistics, some people want the narrative. I often say palliative care conversations is like a house. If you can't get in the front door, try the window in the side. If you can't get in through that window, try the chimney. Not because I'm Santa Claus, but just try the chimney. If you can't get through there, try another back door or another window. And so it's really, I try my different approaches. I really sometimes say, I really worry that I try not to say, like, if this was my loved one, I wouldn't do it. It's really like, I worry that the reality of the situation is this. I sometimes will share stories of patients who have regretted or because they haven't known, but ultimately it is their decision. Shared decision making is shared decision making. You do your best to meet in the middle. And to be honest, the framework that I made as part of my thesis that I showed you at the very beginning does actually have a exit strategy for when there's conflict and you can't either agree or you agree to disagree, and you might need an ethical consult. You might need to ask for somebody to help you. You might need to change position if there's a breakdown in trust, and that's okay. So we're actually, we're at questions already, so it's all good. Any other questions?
There's one more there in the chat regarding the hip fractures.
Let me see here.
From Christine, could you distinguish between subcapital and intratrochanteric? That's
Yeah, so I am not an orthopedic surgeon. I mean, just like everybody else, I would call the surgeon, and if they thought it was non-operative, then it's non-operative, and I go and I discuss with the family. If they determine it's operative, then we have to have a conversation. But even so, for many of our patients, like the patient we have with Ken, going to the hospital to find out if the fracture is operative or non-operative might not be the starting point. It might be, let's keep him comfortable here. We don't need to know if it's operable or not. Similar to whether or not a patient has a lung cancer. who has dementia, who has had weight loss, who has not been able to feed himself. We might not need to know everything about this patient because it likely won't change our management. And it's okay. And living with that uncertainty is hard, but I think that's part of what we need to embrace in especially the frail elderly population.
Can I just jump in with a question here as well, Sarah Polovich? I caught your comment on deprescribing around, I think it was more around diabetes, but one of the areas I struggle with is hypertension. And my question is, how high is too high? So, it's pretty easy when their blood pressure is 90/50 to cut back on their pills. But if they're on a bunch of pills and they have a history of a stroke, and like, I'm just wondering, what would you like? Do you have a limit, or would you? Yeah, what would your goal be?
Yeah, so I actually don't have because everybody's different, right? So a person could get headaches on 160 systolic, or a person can be 200 or be symptomatic. So part of it is symptomatic, like whether or not they have headaches, whether they have visual changes, whether or not they, they're symptomatic, but also in the context of what their functional status is. If they are nonverbal and not eating, we're not going to know, right? So it becomes, are they ambulating and their risk of falling is high versus a higher blood pressure? That's the first thing. The second thing, though, is to, again, share decision making and talking to the families or the patient. Like, this is the risk. Is I'm uncomfortable with your systolic blood pressure of 180. I worry you're going to have another stroke that could suddenly cause your demise, or could cause your functioning to go lower, or for example. And they might have an opinion. They might say, yeah, give me all the pills you need, because I don't have side effects, and I'm from the pills, and I'm okay to swallow still, and I'm okay with that. There's going to be some family members who are going to be very, very vigilant about that. And there's going to be some patients who are like, nope, I don't want pills at this point. I'm 95 years old. If I have a stroke, it's going to be okay because I'm okay with that. And so really it's about shared decision making. It really is. And do I push one way or another? I have to admit, I did start somebody on a third agent in long-term care. I felt very hypocritical doing it. But again, it was with ongoing monitoring and ongoing discussion of the family. And I actually was open with them. I said, like, I actually, my general practice take away blood pressure medications, not add a third agent, but your mom's blood pressure is 200 and she's functioning well and she's walking around her walker. What do you think? And so it becomes very much a shared decision. And it's not, there's no, I wouldn't even say it's not so much right or wrong as is there's no kind of target point. It really becomes where the patient's at and what the philosophy of the patient is and what you're trying to do. Does that help?
Yeah, I mean, yes, it does. I do find that I can really, what I say will often influence families by like quite a bit. So
yeah,
I used to really put the decision on the family, but I have found that isn't always what they want from me. They actually, they want me to give my opinion on what they think. So yeah, I mean, you're throwing out numbers that I would feel uncomfortable with as well. Like once they're approaching 200, I start to get a little twitchy.
yeah, no, right. And so some of it is I know I'm treating my own anxiety because I live in this culture where we do, but I'm also I guess the point is I'm upfront with the family. Like, the risk of not treating this is that she has another stroke. What do you feel? How do you feel about that? And I've actually had patients say that, like, patients' families say, that's okay. If that's the way she goes, that's okay. Versus no. And a similar conversation, but different, is blood thinners. There's some families where I will push to come off blood thinners because their fall risk is so high and they keep falling and I'm worried about hemorrhage. And they're like, no, mom would not want another stroke like she had. keep her on it. And I'd be like, do you know what the cost is? Like, you know, she's got bruising and so it, you know, I'm not trying to cop out by saying shared decision making, but because everybody is so different, I take where they're coming from and I really try to say, okay, be explicit as possible as to what the actual pros and cons are. And then I will push when I say I'm really worried about X, Y, Z. I'm sorry we're over time. Are we good to end this now? Sorry, I have nothing to feedback, so I'm just.
Thank you, Dr. Tan. And thank you everyone for joining. Yeah, hope you guys have a great night and please don't forget to do our survey.
Thank you.
Thank you. Good night.
Have a good night, everyone.
Thanks, everyone.